Hopefully that won't cause. Oh, oh yeah. Good afternoon, folks. We're gonna just wait a minute or so, so attendees can get into the room. We are right at 3 o'clock on the dot. So we're just gonna wait a minute. Thank you all for your patience. Lots of folks still streaming in. Thanks. We're just gonna let some more folks get in. I'm waiting for the number to stop like moving up super quickly, and then we'll make sure everyone's on the same page. All right. We have started to slow to a little bit more of a trickle. Thank you all for joining us today for today's Be Informed session. We are supremely excited to be hosting this one because it's on a topic I think many folks are interested in, and we've seen quite a bit of questions about. If this is your first time at a Be Informed session, just let you all know that it is in webinar format, but we very much would love your participation. So for attendees, you are very welcome to introduce yourself in the chat and give us your name, preferred pronouns, and organization. I myself am Frank Hood. I prefer he, him pronouns. And I am the director of Hep B United, which is a coalition co-led by the Hepatitis B Foundation, where I am their Associate Director of Policy and Partnerships. We would love for you to put in the chat your introduction information. And then as we're going through today's session, if you have questions, please do drop them into the Q&A box. That'll give our panelists a chance to answer questions either throughout the session or have them flagged to be answered at the end. So just as you're thinking of them, don't think you have to try to remember all your questions for the end. You can drop them in the Q&A box and we'll be sure to get to them. If for some reason you run into like a digital issue or something else and have to drop off, do know that our sessions are recorded and should be published on our website within the week's time. In this instance, it'll actually probably be published by tomorrow ahead of our newsletter release. So don't panic if something happens and you end up dropping off. But we hope to have you here the entire time. If you've not been with us or aren't as familiar with Hep B United, we are a national coalition, and we often call ourselves a coalition of coalitions, in that we are an umbrella organization for other organizations and coalitions on the ground who are focused on hepatitis B. We phrase it that way because they could be solely focused on hepatitis B, or, as is often the case, they're a healthcare provider for a jurisdiction or a different or a specific community, like the Asian Health Coalition or the African Health Coalition, who are working on things other than hepatitis, but recognize the need to provide hepatitis B services in their community. So they work with us to do some of that technical assistance, to do some capacity building, and to have a place to really come together with other folks like themselves. This session, the Be Informed session, is something that started in May of 2023 and has been in the works for several years prior to that, really taking our lessons learned from the ECHO program and applying them to something a little bit different. So really tackling public health problems in an ECHO style format with a didactic speaker and case study. And we do this every other month. It is on the third Tuesday of the month. So our next one will be in January 2025. And we really try to take a specific topic around hepatitis B and deep dive onto that. If there is a topic you think would be a good Be Informed session, please do let us know. We really put these together based on what our audience tells us is important to them, what our members say is important to them. We survey as well as just take random suggestions. So if you think that there's something you would like to see kind of explained in this format, please do let us know. For today, this is our schedule, so I'm about to just wrap up my 5-minute intro here. These timings are very loose. We will take the full hour if need be, if it's a robust discussion, so don't mind this one as much. But really just want to say that I am supremely excited for this session, not to put any sort of pressure on our two speakers, but this has just been a session that's been kind of all year in the making, and really excited to have these just two fantastic individuals coming in to explain this for us. So we have Cody Bennett from the Division of Viral Hepatitis, as well as a epidemiologist from Minnesota's Department of Health. But more than that, Jenny is also the co-chair of the Viral Hepatitis Subcommittee for the Coalition on State and Territorial Epidemiologists. And that is important because the Viral Hepatitis Subcommittee was integral in the work that was done in creating these new case definitions for hepatitis B. This has quite a bit of impact on states reporting and other items within viral hepatitis. We get quite a few questions around this topic, so really wanted to bring in those subject matter experts to tackle the questions. And not sure we could have gotten a better combo. We also have Neil Gupta here from the CDC who will be able to field some questions as well. But yeah, with that, I am happy to close my mouth and turn it over to the folks who know their stuff. And let me stop sharing here. And then, Cody, you should be able to share from your side. Excellent. And we do see it. Thank you so much. So with that, I am extremely excited to turn it over to Cody Bennett from DVH. Take it away, Cody.
Awesome. Thanks, Frank. Are you guys able to hear me okay? Awesome. Well, good afternoon, everyone. Really excited to be here. Thank you so much for attending today to learn about the hepatitis B case definitions and surveillance tools. As Frank mentioned, I am Cody Bennett. I'm an epidemiologist, and I work in the Division of Viral Hepatitis at the Centers for Disease Control and Prevention, where I provide support to jurisdictional and public health partners with viral hepatitis surveillance. So I'll be giving the first presentation that will cover hepatitis B case definitions and the evaluation of the hepatitis B case definition. Jenny Grilly will then give a second presentation covering hepatitis B in Minnesota, and will share updates regarding hepatitis B and surveillance. The goal for my presentation today is for you all to have more understanding of the updated case definitions, position statements, and resources for hepatitis B. The first part of my presentation will specifically cover the hepatitis B case definition. So to start off, I'm going to share some background on hepatitis B surveillance specific to case definitions. Acute hepatitis B became nationally notifiable in 1966, meaning CDC started recommending and encouraging jurisdictions to report acute hepatitis B cases to CDC. The first case definition was produced in 2000, and revisions occurred in 2010, 2011, and then in 2024. As you can see by the map, acute hepatitis B is reportable across all jurisdictions, including New York City and Washington, D.C. Now, chronic hepatitis B became nationally notifiable in 2003, and the first case definition was also developed in the same year. As you can see on the map, chronic hepatitis B is not reportable in four jurisdictions in 2023, and this is indicated by white on the map, and data was not transmitted to CDC, or it was unavailable in 2 jurisdictions shown in gray. The goals of surveillance for creating these case definitions are to provide information on the temporal, geographic, and demographic occurrence of hepatitis B viral infection to better characterize the burden of infection and facilitate prevention and control activities. The case definition facilitates identifications of outbreaks and implementation of interventions to halt transmission of the virus, and they are necessary to inform the measurement of hepatitis B care cascades and support hepatitis B elimination activities. Now, let's widen the scope. I'm going to provide an overview of case definitions, including providing a general definition of a case definition, briefly explaining the process for developing all hepatitis case definitions, going into further detail on the importance of the hepatitis B case definitions, and then providing rationale for why both the acute and chronic hepatitis B case definitions were revised. We're going to cover a lot of information, some of which you may already know, but it is with hope that we have similar understanding for when we walk through the hepatitis B case definitions. So, how do we define a case definition? It is uniform criteria used to define an infectious disease or condition for public health surveillance. The definition enables public health officials to classify and count cases consistently at the jurisdictional and national level, but it is not intended to be used by providers for making a clinical diagnosis or determining how to meet an individual patient's health needs. To briefly describe the process for developing a case definition, case definitions for viral hepatitis conditions are developed and updated by updating physician statements by the Council of State and Territorial Epidemiologists, or CSTE, and this is done in collaboration with jurisdictional health departments and CDC. Case definitions are outlined in physician statements, which provide uniform criteria for case ascertainment, classification, and national notification to CDC, and are updated whenever there are major advances in laboratory tests and testing practices. Position statements are then voted on by state, tribal, local, and territorial STLT members, and adoption can lead to changes to STLT laws, rules, or regulations. In June of 2023, CSTE voted to approve a new case definition for hepatitis B that started to apply in early 2024. Cases of hepatitis A, B, and C, hepatitis and C, should be classified by their respective CDC and CSTE surveillance case definition and reported to CDC. Now, I've already touched on the importance of case definitions, including that a case definition ensures standardization and classification of cases, such as hepatitis B cases. But to emphasize this point, a clear case definition is vital for effective management, research, and public health efforts and prevention. A standardized case definition helps in tracking the incidence and prevalence of a condition in a consistent manner and enables public health authorities to monitor outbreaks and assess public health interventions. Here are some figures describing the incidence and prevalence of acute hepatitis B in the United States pulled from CDC's 2022 surveillance report. The first figure, or map, shows that the rate of acute hepatitis B viral infection was the highest in the Appalachian states, seen in dark blue, Florida, and Maine. This is also where rates of acute hepatitis C is also elevated. The second figure displays the number of reported cases of acute hepatitis B, which was 2,126 in 2022, as shown in orange, which after adjusting for case under ascertainment and underreporting, we were able to determine that this corresponds to about 13,800 estimated infections, which is shown by the blue bar. Now, the third figure presents the age-specific rates of acute hepatitis B, showing that the rates are highest among persons from 40 to 59 years of age, which is the dark green and light pink here, and have been the highest since 2020, if we look here. These are examples of how the data of cases that were classified using the case definitions are utilized. This data and figures help inform prevention efforts, which leads into the third point. By understanding the burden of hepatitis B through a standardized definition, aids in resource planning and allocation for prevention efforts, with the primary goal to eliminate hepatitis B viral transmission, and the secondary goal to reduce the risk of morbidity and mortality in persons with chronic infection. All right, so moving into why both the acute and chronic hepatitis B viral infection case definitions were revised. Since 2012, HBV DNA testing has become more widely available. Sensitivity of DNA tests have improved, and expanded screening and testing recommendations have been implemented. Based on these updates and other factors, there have been challenges in classifying cases using the previous 2012 case definition, and this has led to limited measurement and case reporting of the true national burden for hepatitis B infections. Okay, so before we move on, let's take a real quick moment to recap. We just covered a brief but thorough overview of the case definitions. Now we'll dive into the specifics of the hepatitis B case definitions, including the goals for revision, relevant lab tests, clinical criteria, available resources, before transitioning to the hepatitis B case definition evaluation. I have listed here some of the goals for revising the acute and chronic hepatitis B case definitions that came from the physician or from the committee, including to improve the sensitivity and specificity of the acute hepatitis B case capture, allow confirmation of acute cases if no IgM core antibody test result is available, facilitate chronic case confirmation, and create a probable case classification for acute hepatitis B. Here are the relevant lab tests for the hepatitis B case classification, and these are included in the case definition because they play specific roles in diagnosing, staging, and managing hepatitis B viral infections. For antibody tests, total core antibody detects both IgM and IgG antibodies, and it indicates previous or ongoing infection, but it does not differentiate between the two. IgM core antibody specifically detects the IgM antibody and is typically positive in acute infections, which we'll see play out more in the case definition. For viral detection tests, hepatitis B surface antigen indicates current hepatitis B viral infection, whether acute or chronic, and is a primary marker used to screen for infection. Hepatitis E antigen indicates the virus is actively replicating and helps determine the patient's infectiousness. And then HBV DNA, which is a molecular test, measures viral load or the amount of viruses in the blood. While these markers or lab tests, except the total core antibody, were included in the 2012 case definition, they were categorized differently in the updated case definition, as we're going to see in some of the following slides. For clinical criteria, health departments will use this information for case classification if received from providers. So acute onset or new detection of at least one of the following: provider report of jaundice, peak elevated total bilirubin levels, which are greater than or equal to 3 milligrams per deciliter, peak elevated serum ALT, greater than 200 international units per liter. And so to take a quick moment, I will note that the total bilirubin levels, this is new to the 2024 case definition. It was not previously in the 2012 case definition. And then for ALT's levels, this increased from 100 international units per liter to 200 from the 2012 to the new case definition. Okay, so if we take all this into consideration, this also includes the absence of a more likely alternative diagnosis, which may include evidence of an acute liver disease or advanced liver disease, pre-existing chronic hepatitis B, and then other causes, including alcohol exposure, other viral hepatitis, or hemochromatosis. In this part of the slides, I will start walking through the tables to explain the 2024 hepatitis B case definitions and then briefly compare them to the 2012 definitions. These slides are busy as they speak to the complexity of the case definition. And so I will use a black arrow to help track what part of the slide we're on when I get to it. So as we can see here, there's a confirmed and a probable acute case definition. The confirmed case definition has two tiers, and both includes confirmatory laboratory evidence, but the first tier does not require clinical criteria like the second tier. When we look to the second table, we can see there are differences in the confirmatory lab evidence among the tiers, but highlighting that the IgM core antibody test result is not required in the second tier here. The probable case definition was also created and includes clinical criteria and presumptive lab evidence, which includes detecting IgM core antibody. This definition was necessary to create as jurisdictions reported previously creating their own, and CDC was not receiving probable hepatitis B case data. Now, if we look at the 2012 and the 2024 acute definitions side by side, we can see that there are many differences that were necessary as jurisdictional partners previously found it difficult to classify cases according to the current clinical testing practice using the 2012 definition. So the 2012 case definition only included a confirmed definition, which was limited and required clinical criteria, and only an IgM and positive surface antigen or seroconversion. As mentioned, modifications were made to improve the sensitivity of the acute case capture, And this is done by expanding seroconversion periods from 6 months to 12 months, as well as including a positive hepatitis B viral DNA test as confirmatory lab evidence. And again, removing the requirement for a clinical criteria when lab evidence of acute infection is available. So that was a bit to cover, and that was only the acute case definition. Here's a summary slide that provides a high-level overview of the updates that were just mentioned on the new acute hepatitis B case definition. So to increase the sensitivity of the case definition, or really to increase the ability to classify cases correctly, the window for seroconversion was expanded. Additional labs are now considered confirmatory lab evidence, and clinical criteria is removed when sufficient lab evidence is available. To increase specificity or to increase assurance that cases are not false positives, language was added to exclude other causes of liver inflammation, and cutoff for ALT lab values were improved. Additionally, CDC is now required to report both probable and confirmed acute case numbers. As for the 2024 chronic definition, laboratory criteria plays the biggest role as shown in these tables. Clinical criteria are not included as most cases are asymptomatic. The updated definition further facilitates chronic case confirmation with the laboratory categories that include detection of HBV DNA, detection of surface antigen and E antigen, detection of surface antigen or E antigen and total core antibody, detection of surface antigen or E antigen 2 times with the results spaced greater than or equal to 6 months apart. The presumptive laboratory evidence includes detection of surface antigen or E antigen and a negative, not done, or results not available for IgM core antibody. When we look at the 2012 and the 2024 chronic case definitions side by side, we see again that there are a number of differences between the two. Let's start by looking at the presumptive laboratory evidence, since I ended with that on the previous slide. We can see that it was updated in 2024 and is similar to the confirmatory laboratory evidence listed second here. Additionally, HBV DNA was previously included in the same categories as surface antigen and E antigen in 2012, but is now a standalone in the confirmatory evidence for 2024. To summarize the new chronic hepatitis B case definition and the updates, they improve criteria of confirmatory lab evidence, which will likely result in getting closer to the true national burden of chronic cases. CDC is also required now to report out probable and confirmed chronic case numbers. So here are some considerations when looking at the updated hepatitis B viral infection case definition. The hepatitis B viral condition and associated laboratory tests, as we all know, are complex. So cases may be misclassified or reclassified as additional data is reported to the health department. The case definition is not implemented the same across jurisdictions, as reporting regulations of lab results and other information do vary. This leads to jurisdictions dealing with missing data that will impact case classification and impact reporting to CDC. When building out or updating a case definition, it is also important to try to balance sensitivity with specificity, as it's clear that this impacts total case numbers. And then additionally, social stigma around hepatitis B and limited access to testing in some low resource settings lead to delay or unreported cases. These challenges highlight the need for flexibility and continuous evaluation of the hepatitis B case definitions to ensure that they align with the current diagnostic capabilities and public health goals. Here are some resources and guidance that can help inform you all a little further past the presentation and the discussion today. The NNBSS website linked here references to the CSTE position statement, the current and historical case definitions, and the historical timeline for implementing the nationally notifiable condition. The CSTE hepatitis B position statement linked provides, again, the case definition, but also criteria for case ascertainment, disease-specific data elements to be included in the initial report to Public Health Department, as well as additional information to support to put together the hepatitis B viral infection case classification and the case notification to CDC. And then the guidance for viral hepatitis surveillance and case management includes a number of different topics, including the ones here, such as surveillance case definitions, case ascertainment, case investigation, and case reporting and national notification. All right, so now we're moving into the second part of the presentation where I will give key findings from the hepatitis B case definition evaluation. The goals of the evaluation were to partner with jurisdictions to understand how the updated case definition would impact surveillance trends at the jurisdictional and national levels, and to compare case counts of acute and chronic hepatitis B using the 2024 and 2012 definitions. To simplify what I just said, we asked co-investigators to use the same year of data, apply both the previous and updated case definitions, and compare the differences in numbers. DBH worked with the 9 jurisdictions listed here on the evaluation project and received data from 7 of them. Jurisdictional partners analyzed acute and chronic hepatitis B case data from 2022 and shared aggregated data tables with DBH for analysis. The evaluation included a number of goals, but I'm only going to share results from 2 of them today. The first goal was to summarize data, including determining the number and percent change of acute hepatitis B cases identified based on the 2012 and 2024 case definitions. The table on the left shows that 296 confirmed acute cases met the previous case definition, which increased to 490 cases meeting the new case definition, which is a percent increase of 66. The table on the right displays that a total of 53 cases met the 2024 or new probable case definition. Both tables were broken down by the jurisdiction to show the differences in case numbers and the percent change. These numbers would be impacted to show by some of the considerations we've already mentioned, such as differences in reportable and received labs, but also because of capacity for the public health department to conduct case investigations, which could be impacted by high case burden, jurisdiction population, and that list does go on. This slide displays the same goal, but for chronic hepatitis B. Confirmed cases, again, is shown on the left, and the probable chronic cases shown in the table on the right. For confirmed chronic cases, the percent increase for total cases was 237, with a range of percent change from 58 to 458 for individual jurisdictions. For probable chronic cases, a percent decrease is shown for 6 out of 7 of the jurisdictions, with a total percent decrease of 48. The next goal was to summarize the number of 2022 cases that switched case classifications from the 2012 case definition and 2024 case definition. This table summarizes data for 6 out of 7 jurisdictions, so the numbers will not add up to the total number of cases previously shown. The 4 middle rows on the left display case classification based on the previous case definition, and the 4 middle columns represent case classification based on the new case definition. The gray cells represent the concordant, and the red cells represent discordant or changed classifications. For instance, there are 224 cases classified as confirmed acute using the old case definition, and 222 cases remained confirmed acute under the previous case definition, while 2 cases were reclassified to confirmed acute. Additionally, of the 8,485 cases initially classified as probable chronic under the previous case definition, 111 cases switched to confirmed acute. 4,013 cases remained probable chronic. 4,361 cases were reclassified to confirmed chronic using the new case definition. In all participating jurisdictions, the number of cases meeting the updated hepatitis B case definitions increased relative to the prior definition. The magnitude of change varied widely, likely due to differences in capacity to conduct case investigation and reportable labs. Overall, there was a 66% increase in the number of confirmed acute hepatitis B cases and greater than 200% increase in the number of confirmed chronic hepatitis B. The results highlight the increased sensitivity of the 2024 acute definition and will help explain when there's an increase in the 2024 chronic confirmed data. And at this time, I will stop sharing and hand the screen over to Jenny.
Thanks so much, Cody. Let me see if I can steal screen sharing from you here. There we go.
And as Jenny's getting that pulled up, please remember, I thank you to those who have dropped a question into the chat or the Q&A box, and please continue to do so as we go through Jenny's presentation, and we'll move into answers after that.
Yeah, is it showing on the screen? It doesn't seem like it is.
No, it seemed like it was popped up for a split second and then kind of dived back out.
Yeah, let me share it in a different way and see if it likes that one better. All right, how does that look?
That looks great.
Perfect. All right. So my name is Jenny Greeley. I am the Hepatitis Unit Supervisor at the Minnesota Department of Health, and I'm going to talk today about hepatitis B in Minnesota, very high level, and then hepatitis D, which I'm going to try my absolute best to refer to as hepatitis Delta, because B and D sound very, very similar. So kind of just following on and tacking on to what Cody had been talking about with the chronic hepatitis B case definition, diving a little bit more into the Minnesota data, and Cody shared this as well, but wanted to kind of highlight it for Minnesota, is that these changes in case counting began in 2023 is when that passed, which means it was implemented for the first time January 1 of 2024. So when we look at kind of what the breakdown looks like within Minnesota, what we did is we looked at individuals who were reported in 2022 and the labs that were reported along with them in that time period. And so using the old classification, Minnesota had 95 confirmed chronic cases, which is very, very small when you look at how things appear under the new case definition, where we had 507. So it's a really, really big impact on what is going to be showing up in the data as far as confirmed chronic cases, and to a much lesser extent, but still notable, with acute cases as well. So kind of what does this mean and how we need to conceptualize it is that the national data on hepatitis B will shift very dramatically. And while some of that is really related to just, at the core, the case definition change, a big piece of it too is that, this was, probably long overdue, that we really needed to start thinking about classifying hepatitis B cases in a different way. So some of it too is that at a national level, probable cases were not reportable, so they weren't being published. So we were missing just a really big piece of what was happening with hepatitis B in the US. So one of the things we really have to think about is that as this data come out at the national level, that we're messaging these data appropriately, that people understand that some of this is related to a case definition change. It's going to be difficult to pull out what might be true increases in hepatitis B and what might be related to the case definition change. So we need good messaging. We don't want to cause like huge false alarm, but also we need everyone to really be rooted in the fact that this was there all along and we just weren't set up at a public health level to be able to classify it in this way. So that being said, that doesn't necessarily mean that each jurisdiction, so each city or state or province, whatever we're talking about, was doing this in the same way. So at the national level, only confirmed cases were being reported. And so now going forward, we'll have more confirmed cases. And that's kind of like the big heavy hitting number that we often look at in the hepatitis world. But then additionally, we're going to have probable cases now, because those are also now reportable to CDC. So again, big impacts at the national level. Depending on if you're working with a particular jurisdiction, that may not be as noticeable. So it's really up to all of us to really understand kind of how these data are collected and reported. So for example, in Minnesota, we do include confirmed and probable cases together when we talk about our chronic cases. So for us, our data are not going to look any different because they've always been lumped together. So, then when it comes out at the national level, there may be some alarm if we look at national Minnesota data, how that's going to look, because we've always been talking about it in this more aggregate way at the state level. That is definitely not the case for every jurisdiction. There's some jurisdictions who do very little with hepatitis B. There's some jurisdictions who follow the same way that CDC has been doing things. So it really is important, depending on kind of what level of data you're looking at, that you really understand a little bit more about what's going on behind the collection, interpretation, and reporting of these data, which is really why we're here today. So as Cody said, we could see potentially a greater than 200% increase in the number of confirmed chronic hepatitis B cases. So this is just a really brief comparison of the CDC data that had been published through the Division of Viral Hepatitis, and then what we saw in Minnesota. So when we look at the confirmed cases of hepatitis B, what was reported out with 2021 data was 240 cases in Minnesota. 2022 data at the national level was just under 200 cases in Minnesota. And then 2023 and 2024 have not come out yet at the national level. So we still have another year of data, 2023 at the national level, that's going to be under the old system, under the old case definition. And then when 2024 data are released, we will hopefully be seeing the impact of this case definition change as jurisdictions adjust to where things are at now. So 2023, 2024, still coming up when it comes to the national data. But it does again mean that we have a whole nother year of data that we may start seeing jurisdictions reporting out 2024 data that could potentially look a little bit drastically different when it comes to the national data coming out on a similar time frame. And it's just because national data obviously is going to take a whole lot longer than if I just throw my data together for Minnesota. So we've got another year of national data where we know we're not going to see the impact of this yet, and that won't necessarily be the case at a lower level, like at the state or city level. So when we look at the Minnesota data, we had, in comparison to the 240 that were reported by CDC in 2021, we had about 520. 2022, we had about 560. And then you can see those increases for 2023 and 2024. So there may already be a question on the tip of your tongue of, is Minnesota seeing more hepatitis B cases? And again, this is where it really comes into understanding what's happening as far as counting cases and how we do the work that we do. And so as an epidemiologist who works with this data, no one asks me about this data. So please feel free to send questions. And I'm sure my colleagues in other jurisdictions feel the same, and would be happy to kind of give a little one-on-one on how we put our data together. So we're seeing, these increases from 2022 to 2023, already up to 600 when we don't even have a full year of reporting in 2024 yet. But another thing that happened around this time period is that when we changed the case definition, we also included that the total core test for hepatitis B became a whole lot more noteworthy than it was before. Not that it wasn't important, and not that we didn't kind of use it to the best of our ability, but it actually was added to the case definition itself. So for example, in Minnesota, we went from a jurisdiction that said, we can barely handle what we're getting already. Please don't send us total core results. We can't handle it. To, we're going to figure out how to handle it. Please send us all the positive total core results so that we can make sure that we are getting all of those. So a big piece of this is that those numbers shifting are because we're able to confirm more cases because we now have an additional test being reported to us. So I don't have our probable data on here, but our totals, when we combined confirmed and probable, we do, still see a pretty similar number. But again, when we look at this, it looks a little bit alarming, like what's going on with hepatitis B in Minnesota. So it is really important to understand kind of behind the scenes how those data are being collected and reported. So we're going to jump ship over to hepatitis Delta here. And actually, I'm sorry, before I do that, there was one question in the chat that or in the Q&A that I marked as answered by accident. But it was, why is there a difference between case definitions and clinical diagnoses? And that's a great question. And it's one that I think all of us in public health probably have had to learn as we talk to clinicians, because we use words differently. So I think kind of one of the best ways to explain it is the word acute, for example. So acute in the public health world means we're trying to find people who are newly infected, versus acute in the clinical world can have, you know, a couple other definitions. One of them being that someone is acutely ill. So I know in my early years as an epi, just having conversations with clinicians who would say, you know, this person has acute hepatitis. And I would say, they don't have acute hepatitis. We know they've had Hep B for 10 years. And we were saying different things, but kind of in the same way. What they're saying is that this person is acutely ill from hepatitis. And what I was saying is they don't have a new infection. But we were really, you know, talking in our lanes appropriately. So a piece of it is that our terminology differs in the medical world versus the public health world, not drastically, but a little bit in some notable ways. The other piece that really comes into play too is that clinical work is at an individual level versus public health is at a population level. So when it comes to counting cases and looking through data, we're often dealing with thousands of people. And so we need to be able to have a really simplified, as much as possible, standardized way of looking at each individual person because we have so many people that we're looking at one time. The other thing is we just really don't have the level of clinical information that a clinician might have in front of them via a medical record. You know, things like Care Everywhere means they can access so much more, whereas we might just have a test result. And that's really all we have to go off of. So our world is really just like a very narrow crack that we can peek into someone's healthcare to be able to understand what might be going on with a specific disease. And Cody, if you have things to add to, just note that I marked that question as answered live. So hopping into hepatitis delta. So I'm guessing a lot of us know this, but just really quick overview. Hepatitis delta is a liver disease caused by the hepatitis D virus. It can only replicate in the presence of the hepatitis B antigen, which just means that only people with hepatitis B can contract hepatitis D, either B first and then delta down the road, or both at the same time. Hepatitis D is vaccine preventable. It's like my favorite trivia fact in the hepatitis world is that there is another form of vaccine preventable hepatitis, which is Delta, because if someone is vaccinated against hepatitis B and they won't get hepatitis B, they're not going to get Delta either. So it's got the places where it's most commonly seen, really similar to hepatitis B, but not a perfect overlap by any means. And so there's two kind of worlds when it comes to Delta. There's co-infection, which means becoming infected with both viruses at the same time. You would think that like a double hit there would actually be a bad situation. And it certainly can cause serious short-term health problems, but it usually doesn't result in a chronic infection. And a lot of times we do see people actually resolving both infections and not having, you know, really, really negative health outcomes. Versus superinfection, where someone is already infected with hepatitis B and then later on contract Delta. And so that can actually really lead to some very negative health outcomes. So it can lead to rapid development of liver fibrosis, liver failure, and even death. So it really can, you know, in someone who's already got a longstanding liver disease, really, really complicate their medical picture. So, excuse me. So what are the testing recommendations for hepatitis D? So we're not in Europe, but I wanted to throw out one that differed from ours. So the EASL recommendation is screening in all hepatitis B positive persons. So anyone who tests positive for hepatitis B should be screened for hepatitis D. That's how it's done in Europe. In the US, we have AASLD recommendations, and those are still risk-based screening. So we've got our risks listed here. And really, I think that last bullet is particularly notable as patients from endemic areas. And, you know, that's really going to be our people with hepatitis B for the most part, not entirely. People can get hepatitis B a myriad of ways. But at least when I speak for Minnesota, so many of the individuals living with hepatitis B are because got that infection at the time of birth being passed on from a parent, or potentially through sexual transmission in the countries where they were born. So the risk factor is that they're from endemic areas, but it's really, I mean, for the most part in Minnesota, so much of Hep B is this last bullet here. And as we know in the hepatitis world or in the public health world in general, that risk-based strategies are limiting. Healthcare providers don't have the time. Some of them don't have the comfort level to talk about risks. And some individuals are not in that place with their healthcare provider to mention their risks either. So, really just encourage testing for hepatitis delta in all patients who have hepatitis B, especially those who have chronic hepatitis B who suddenly show rapid progression of disease, because that could be an indicator that we've now got another liver disease on board. And want to make very clear, I am not with any recommendation making agencies, so I can say things like that and throw it out that everyone should just consider this. So when it comes to case counting, we now have a standardized case definition for hepatitis delta that's going into effect January 1 of 2025. So past this year, going into effect next year. And it allows us all to count in the same manner. So these data are not being reported to CDC. They're not being counted at the national level. And I have yet in parentheses there because that's not where we are yet with public health and hepatitis delta. But hopefully someday we will be there. So the test that we're looking at for delta is hepatitis D RNA, and that is someone who is a confirmed case. And now we all got our case definitions one-on-one with Cody, so I know we're all experts now. And then individuals who have a total antibody for hepatitis D is a probable presumptive case. So to look really quickly at Minnesota data, we started to separate out our hepatitis delta data from our hep B data in June of 2023. Before that, we smushed them together into hepatitis B, and we wanted to further differentiate the delta world as we start counting those data. So we had, in that time period between June 2023 and about end of October, we had 49 individuals reported with positive delta testing in that time period. And then additionally, we had 209 people who were already in the system with one of our two tests that we're looking for. So most of those people had a total antibody to hepatitis delta, and then about a fourth had a detectable RNA. This could tell us a lot of things. It might be that we're not doing enough RNA screening. We don't get the negative. So maybe these total antibody folks had a negative in there. Really kind of where we're at is it maybe doesn't tell us a lot yet, but that's because we're so early into counting it. And our first step is to count the same so that we can understand what happens in our jurisdiction compared to what's happening in other jurisdictions. And so when we look at the total number of people alive and living with hepatitis B in Minnesota, that gives us a co-infection rate of less than 1%. Do I think that's accurate? Very unlikely, but it's a place to start. We know that we've got a co-infection rate, and from there we can do better work to figure out, are people with hepatitis B who live in Minnesota being tested for delta? And if so, what are we finding? We can talk with clinical partners and start doing some of that advocacy work. So I'm going to skip this slide, but it is a really good demonstration of why this work around hepatitis D is particularly important. And I'm talking about it even though I said I'm going to skip it. But if folks are very interested, I would encourage you to look up the hepatitis D outbreak in Washington in the year 2000. They really saw some very dramatic impacts of hepatitis delta co-infection in the population that they were working with during this outbreak. But I want to talk about next steps and then I have time for questions. So kind of where we're at with this case definition is to notify stakeholders of the new case definition and surrounding advocacy efforts, which is what we are doing today, to advocate for more routine delta testing for people who are living with hepatitis B so that we can actually get better data to understand what's happening with delta in the realm of hepatitis. And then we need to make sure that our labs are, for jurisdictions that have this reportable, that our labs are appropriately reporting it. Because it really wasn't top of the list of the things that we were working on, we don't know how well our labs are reporting. We'd like to think they're reporting well, but we won't know until we look into that. None of the tests for hepatitis delta are FDA approved. And so we need to get there. We need to have people prioritize testing. We need to show that there is a market for these tests and that we really want to get to the point of having FDA approved tests that we can trust and rely on and implement into our case definition so that we can start maybe one day counting nationally and understanding the landscape of delta in the US. There are a lot of public health jurisdictions that don't have hepatitis delta as a reportable disease. And so supporting the jurisdictions that are able and willing to make that move to make it a reportable disease to start collecting data. And then lastly, at least in Minnesota, we really don't have patient and provider educational documents around Delta. So we need to fill that gap and make sure that we have those. As we're encouraging providers to test for Delta, we need to make sure they have the resources to educate themselves and to educate their patients as well. And I will stop screen sharing so that we can tackle some questions.
Thank you both so much, and I appreciate you both answering some questions in the Q&A. I do see that we have one question that Cody would like to answer live. Cody, do you want to tackle that now or field a different one first?
Yes, I would. Are you able to hear me okay?
Yes.
Okay, I may be frozen, so I'm going to shut off my video just to save bandwidth. But yes, okay, so Daniel Raymond asked how we can understand these shifts from the new case definition in the context of the national prevalence estimates from samples like NHANES. So just a little bit of information on NHANES, and Neil, please feel free to jump in on this question as well. But they're different, right? So NHANES can't really differentiate acute cases from chronic, and NHANES supports national estimates of prevalence of current infection, past infection, and evidence of vaccination, so likely chronic infection. Also, the NHANES sampling derives a nationally representative sample of, the civilian population, non-institutionalized population from U.S. households in about 15 counties per year in about 15 states. And then also NHANES is a great estimate. I'm just letting you know the differences. NHANES does not include, people living in correctional facilities or other group settings, people living in sheltered, active military duty personnel. And then there's not information on country of birth, etc. So those are some of the things to keep in mind as we're looking at the shifts, data coming in from the new case definition specific to chronic, and then data from NHANES, which may not represent all of the population that may be at risk for hepatitis B. And then I'll pause to see if Neil or, Neil, go ahead.
Sure. Hi, everyone. First of all, apologies. I'm actually at the liver meeting in San Diego and in the crowded airport lounge, ready to fly back to Atlanta. So I'm sorry I'm not on camera the whole time. Yeah, I think, Cody, you summarized it well. I would just think about NHANES and a little bit differently than chronic hepatitis B surveillance. NHANES is looking at a snapshot in time, all prevalent infections in the country. Cody already well highlighted where it does well and where there are some gaps. But just think about it saying, okay, I just want to take a snapshot of who has hepatitis B in the country and what are the characteristics of those people. Chronic hepatitis B surveillance that we covered today is different. These are not necessarily prevalent infections. This is really trying to capture who is a new diagnosis of hepatitis B, a chronic hepatitis B, that has not been previously reported. That is what we're trying to essentially understand with chronic hepatitis B surveillance. And so what we do with this information is then understand who are we testing, where are we seeing positive results, where do we maybe need to expand our testing resources. That's an example of a public health use case for chronic hepatitis B surveillance, whereas NHANES might give you a sense of overall, what are we seeing nationally? Is this number going up or down? Obviously, what are the limitations of NHANES and what additional data sources do we need to supplement the gaps? And then you can do a lot with NHANES looking at race, ethnicity, country of birth, insurance status, etc. So they have strengths and limitations, but I would say the biggest is that their overall goals are slightly different. Hope that makes sense.
Neil, thank you. That was super helpful. Frank, there was one question in the chat that I said that I would present a slide again. Is that okay right now?
Yep, absolutely.
Okay. So I was asked to present the 2024 chronic. There we go. Laura, did you have a specific question on this? And then maybe it'll come in, but maybe she's gonna screenshot it. So I just wanted to share this again, and happy to share additional slides if that's helpful, Frank.
No, that is really helpful. As we wait for others to potentially pop in a question, and I do think there might be one in the chat as well. I'm curious if after this process occurred at CDC, working with your state partners and recognizing that the new case definition was going to result in a more accurate count of the burden of hepatitis B in jurisdictions, if there are already conversations about how to sort of tackle this increase, which, as I think has been heavily said, is not really an increase, it's really just catching the things that are already there, but is showing anywhere from 66 to more than 200% kind of increase in disease burden that we now have to rectify. Is there any sort of sky is falling running around at CDC or other maybe more measured conversations? Because I would know that if this came out without this sort of background, like the advocacy community would get real fired up real quick. And so just curious if there's already some just shifting in how to address Hep B nationally, given that we have a more accurate understanding of its burden.
I will say that the evaluation we did does capture data from 7 jurisdictions, right, Frank? So we know that we're going to see an increase, but we don't know what that increase is going to be yet. And so sky's falling, no, not at least for that reason. But I think, there are conversations that are happening and that will continue to happen, not only with the CDC, but with jurisdictional partners, who can really provide input that's necessary for CDC to do the work we're doing nationally, provide that guidance nationally, and provide the information that's needed nationally. But so I will say that's one thing, working with CSTE, jurisdictional partners, as well as in building up surveillance at that level for hepatitis B specifically, so acute and chronic hepatitis B, hopefully in the future. And so those are some of the things I can think of, but I will let Neil come off mute if he can think of anything else.
Yeah, sure. It's a great question. Sky is falling, no. I would say that, we're used to doing this in surveillance, is really having to explain why numbers change as a result of the case definition change. Having said that, this is a big one, right? This is a big change in the case definition, and I think something that's, we've been in the works actually for quite a few years. I actually got started all this before COVID, and then we got stalled. So I think it is going to be really important that we explain this, particularly so people can understand it. Again, what we are doing is not saying necessarily that the number of hepatitis B infections has increased over this time. It's the number of identified chronic hepatitis B infections, and that essentially we're almost giving a new number. It's a new way of defining chronic hepatitis B. I think that's going to be important. The evaluation that Cody and Jenny and others participated in, which, by the way, we're so grateful for the states that could do that, we're not going to be able to do that in all over the country. It takes a lot of work to do something like that. So we're going to be using the information from that to really extrapolate. When we present these new data, and we have some time because it won't be until the 2024 data are final and ready, we're going to have to say, hey, this is what we think are the effect of a new case definition change on these new numbers that you're seeing, and be able to explain those trends. We did actually have to go through this with hepatitis C recently in 2020, and it's a little challenging, but and really more for us, it's challenging because we can't really interpret our trends, be it before and after. So, moving forward, you'll see our graph and you'll see a little arrow and say, this was when a big case definition change happened, and we just have to acknowledge that. But this evaluation was incredibly helpful for us, at least to understand how in these jurisdictions, how it impacted them. But you saw even in those 7 jurisdictions, the difference was very different, right? I mean, it affected their counts very differently across the jurisdictions.
Thank you for that. That's a really helpful explanation.
I was going to say one thing back to the prior question, Cody or Jenny, maybe unless you've already done it, it might be helpful to just put the web link for the online case definition and the position statement if you haven't already done that, or we could circulate that, because I know that if people want to look at the lab criteria, they can look at that on their own time as well.
And the links that Neil mentioned are also captured in Cody's slides. So when those go back around, folks will also have that. We are coming right up at the end of our hour, so I do want to say some thank yous, but right before that, just want to note that this is a fantastic shift in the case definition, mainly because we're getting more accurate data now, and at the end of the day, more accurate data is like what we care about, in public health. But I think it's also just so well timed because we see, in the not too distant future, a shift in how Hep B diagnostics will be, but hopefully delivered here in the U.S. and have the opportunity to maybe capture more folks on the ground, but maybe not with like a triple panel and maybe just one of those three. And so to be able to still have that count towards surveillance data while also getting those folks linked into care to somehow, it's going to be a really great 1-2 punch if we're able to kind of move forward with that point of care or other easier Hep B diagnostics. So I'm glad that this is going to be set up and ready for that potential shift on the ground. Besides that, though, just really want to thank Cody and Neil from the CDC, as well as Jenny from Minnesota/CSTE, for just all the time you all have taken over the last months to put this together and to get through different permissions and other pieces. We had more than 100 folks on today, and we recorded this for distribution. So really expect just some really positive ripples to come out of this last hour, and just would not have been possible without you three, really jumping on board and agreeing. So just want to give you a full-hearted thank you. And if folks had questions they didn't get answered, please reach out to me or Shreya or anyone else on the Hep B side, and we can forward those questions along. We have a great working relationship with the center, so happy to get those forwarded and get your questions answered if you weren't able to this time. All right. Well, I appreciate everyone sticking till the very end of the hour. Anything, Neil, Cody, or Jenny, you want to say as we wrap?
If I may say one thing, first of all, thank you for your interest. We really appreciate it. We know it took a little while to get this to you, but hopefully it was helppful. I really did like some of the questions I saw in the chat that were maybe more geared towards the epidemiology and what are we saying. So I would offer, when we have our next annual data out, I would love to do a deep dive on hepatitis B trends and epi and what are we seeing, and ask, we are okay with challenging questions and what can we do together to address this. So we don't have a dead timeline yet, but 2023 data are in preparation, and or hopefully early next year when it comes out, we'd be happy to do a deep dive, and would love kind of more of a collaborative conversation. What are you seeing? What does this mean? And what does it mean for opportunities in terms of intensifying efforts? Or so let us know if that would be helpful to you, and we'd love to do that.
Oh, we'll hold you to that. It's recorded. We had many witnesses. That'll happen. Don't worry. Anything from Cody or Jenny before I end the webinar? All right. Well, thank you all. We'll get the recording posted quickly, and we hope to see you on the third Tuesday in November, which will be the 21st. But yeah, have a great rest of your day, everyone.